Hi, everybody. This is Rajam Roos, the founder and the CEO of the San Diego Pain Summit, and I'm here with Dr. Bahram Jam, and he has agreed to join us and talk to us a little bit about some of his work and ideas and thoughts of what clinicians should know in their practice. And he graduated from the University of Toronto and then completed a clinical master's in manipulative physiotherapy at the University of Queensland, Australia. He also completed his doctorate in science and physical therapy at Andrews University, USA, and he has a Canadian Diploma of Advanced Medical and Manipulative Physiotherapy and is also credentialed with the McKenzie Institute International. He's the founder and director of Advanced Physical Therapy Education Institute, or APTEI, and has been a chief instructor for over 1,000 postgraduate orthopedic clinical courses across Canada and internationally. He's presented at several national and international conferences and continues to practice at Athletes Care at York University in Toronto. So welcome, Dr. Jam. Thank you so much for joining us today.
My pleasure. You can call me Bahram.
Bahram, yeah, so sorry.
Yeah.
I'm from the South. We're very formal.
I know.
Told otherwise. So, I was curious, one of the more popular pieces of content that you have put out that people talk about a lot and seem interested in, and some viewers may not have heard about it, is your V.O.M.I.T poster. And I believe that's it behind you.
Yes, it is.
Okay. So because that's kind of a vomit poster. What does vomit mean?
So V.O.M.I.T stands for the acronym Victim of Medical Imaging Technology. And in fact, about 3 years ago, I changed it. It's no longer called V.O.M.I.T. I don't have it in there. Not because the word vomit was bad, but at the request of some other clinicians, they said they didn't like the word victim, which I agree with.
Oh, okay.
They become a victim because it goes against all my beliefs that we don't want to label patients.
Mm-hmm.
So I changed it to the medical imaging, the untold truth. But I still, to popularize it, I call it V.O.M.I.T.
And what inspired you to create this poster?
Basically, 5 years ago till this day, there's not a day goes by when I'm at the clinic where I don't see patients who've become V.O.M.I.T, who've become a victim of medical imaging technology. And you can tell patients, you know what, it's normal that lots of people have knee arthritis, lots of people have hip arthritis. It doesn't mean you have to have pain or degenerative disc disease or disc bulges or rotator cuff tear. But when they're told by their doctor or their orthopedic surgeon or radiologist report that they read on their own, and then they Google it, they're doomed. People literally go down a spiral. That's really hard to get them out of. But I found if there was something written in print with all the references at the bottom of it, then it's not just me saying it. The truth is, it's really hard to convince people otherwise when a doctor has told them this information. So I thought we need something in a book and we need something in print. So I said, I'd make a poster in order to convey this message. And I'm happy to say now, after 5 years, there's been thousands of distribution of that. Over 5,000 of this poster have been distributed now. And it's been translated into 8 languages, which I'm very happy about: German, Italian, Norwegian, Spanish, Mandarin.
Wow.
And it's gained popularity, but obviously because every time I see patients, I see vomits pretty much every clinical day, it's not getting around enough. It's getting around to clinicians who already know this stuff, but not to the ones who are either not willing to accept it or just, I don't know, they not up with the times. They want to deny the evidence. So I don't know why it's not going to everyone, this information yet.
And it's interesting what you said about part of what inspired you to do it was the fact that when you see a patient and their physician has told them something, it's really difficult for us to change their minds. And what's interesting about that is one of the other people that I spoke with who's a patient who has become a clinician, Amy Eicher, and we had this in another discussion on this forum, is that she said as a pain patient, when she went to see physicians who actually had told her similar information, she didn't believe it because her initial physician and physical therapist had told her another story. They had given her a vomit story. And that's what she believed. but because of that, it was many years of seeing many practitioners that she just wouldn't, she would just blow them off because it didn't match that first. So to that in mind, what would you say to clinicians who maybe they haven't been using your poster, they're listening to this, they're going to go download it, they're going to get it. How would they present that to a similar patient who maybe come in and they're showing them the poster and the patient's like, but you can tell they're not, they're skeptical. How would you address something like that?
Excellent point. If I could only change people's minds in one session, it would be miraculous. It doesn't happen. It happens sometimes, right? But not often. The number one thing I need before you present vomit information is you need therapeutic alliance. Meaning you have to build that connection with them, that they trust you. If you right off the bat say, oh yes, you have degenerative disc disease in your neck, but that doesn't mean anything. The studies show 98% of people have it and don't have neck pain. My grandmother has degenerative disc disease and she has no neck pain, right? And you can say that, you just offended them. So they'll say, wait a minute, you jerk. I know I have degenerative disc disease because my pain is real. And the doctors told me that. The radiologist report said it is. I don't care about your stats and stuff. I'm different. My neck pain is from my arthritis. And actually, they'll push you away and you lost them. So if you introduce this stuff too early, you'll lose them and it backfires on you. If you introduce it, kind of at the right time, you build some therapeutic alliance, you may get what's called cognitive dissonance in a psychological term. Because you just introduce something that goes against the core belief. And then they'll go, wait a minute, this is messing me up. And that's not too good either, having cognitive dissonance. It's like going against somebody's religion, right? They believe it so much, evidence doesn't matter. It's just what I believe. Until you have that ultimate therapeutic alliance, and you don't want to directly say, oh, degenerative doesn't matter. You have to do stuff to prove to them. For example, I have somebody with knee arthritis. They say, I can't run. I make them jump. And I make them run on the treadmill. They say, I can't walk. I make them run on the treadmill. And I say, how does that feel? So actually, it doesn't feel bad. I feel no worse after doing it. Great. And then eventually they say, wait a minute, my doctor never made me run. You made me run, and I actually don't feel bad. And then I got them in the palm of my hand. So I always have to do something physical in order to prove to themselves what their belief maybe is not accurate.
And is that what you...
Yeah.
And I was just going to say, is that what you would consider like a crucial step in creating that therapeutic alliance, is showing the patient that who's saying they can't do something, if you can show them that they can do something, would that be one of the first steps to creating that? Is that what you're saying?
Absolutely. Sometimes I may not be able to, make them do stuff, but at least through my communication, building therapeutic alliance, asking them about their hobbies, activities, their dog, and, the typical empathy things. I say, oh, that must be really difficult for you to do that. I've made a connection. So even if they can't turn their neck, because of the arthritis, they believe, then if I say, you know what, I think it's muscle tension. I don't think it's the arthritis that's causing this. Then it's gradual. Maybe it's not on day one. Other people like I had today, right off the bat, I had a guy who came to me almost in tears, 60-year-old guy. Just 3 hours ago, I just came from the clinic. He had gotten 2 CT scans and 1 MRI. And get this, are you ready for this? He had no pain and he got that stuff. Why? Because he had some kidney pain. They were worried about a kidney cyst. He just coincidentally got that stuff. Since then, because he was shown that he had a grade 1 anterolisthesis of his L5 and S1. So he's got this in the last year, 2 CT scans and an MRI to prove this anterolisthesis, 9 millimeters. Since his teenage years, he's had this probably. Mm-hmm. He stopped playing soccer, which he's been playing for about 50 years of his life. Till he's 60. He's part of a league, and they told him for the last 3 months, don't play anymore. You're going to wreck your back. His wife said, don't lift the coffee table because you're going to wreck your back. And he was even sent to a pain clinic. And the doctor says, why are you here? He goes, I have no pain. He goes, I don't know. They just sent me to a pain clinic because this anterolisthesis is disastrous that they see on X-ray. And so basically I said, there's no association with that and pain. There just isn't. And in fact, I got good news. You're too old for it to get any worse. You're already degenerated. It's not going to move. But he was told it's going to move. And so I said, you can go. I literally went outside the clinic and we jogged for 10 minutes. That was my therapy. We ran, we sprinted, we switched directions because that's what he would have to do in soccer. Then we came home. I made him lift 40 pounds because his wife told him not to. And he was scared of doing lat pull downs at the gym. I made him do 3 chin-ups. Did that hurt? No. But you've had this all these years. So if he hadn't seen me, because he had already seen 2 other physical therapists though, and he had seen a chiropractor, and he had received traditional Chinese consulted a traditional Chinese medicine on how to prevent it going further. But he didn't have any pain even. That's one of the rare cases. But he was just fearful of not doing activities. He just wanted to get opinions.
Wow. Wow, that's a really good story. So when you're when you've reached that therapeutic alliance with your patient and you're sharing the parts of the poster, where do you start when you're looking at your poster?
The poster, can I show it? Just show it here. You don't read the entire thing. I know it's a very busy poster. You just have to read the section that's relevant to you. If they come to me with heel pain, I just read the ankle part. And the ankle part, basically, heel pain, if they've gotten x-rays often, they say, I got a heel spur. And many clinicians don't think that you can become centrally sensitized locally at the heel because they think of like central sensitization as fibromyalgia. But the truth is, I've had patients who've been centrally sensitized with local heel pain because of their beliefs. Their belief is something's damaged in my heel. I got plantar fasciitis and my plantar fascia is torn, and every time I walk on it, it tears apart. The region becomes sensitive. Or I got this bone spur in my heel. And I tell them, do you know what percentage of people, if you took everyone and you took x-rays of them, what percentage of people would have a spur in their heel? 1 in 3 people, 32%. So then it means 1 in 3 people should have heel pain for the rest of their lives, because the truth is bone spur never changes once it's there. And then it's logical. Do 1 in 3 people have heel pain for the rest of their lives? The answer is no. So because they expect the heel spur, it's going to be forever. It is. But the pain goes away despite the spur. It's not relevant. But when they have that image of a spur, that's it. You become centrally sensitized.
Hence the, what does V.O.M.I.T stand for again?
Victim of medical imaging technology. They become a victim of medical, and because they've been told they have a heel spur, which is frankly irrelevant. There's 0 studies to support that the heel spur is actually the cause of pain. It's there, coincidentally.
Something I find interesting, when I had a massage practice for 16 years, and something I found interesting was I would, and we just call them clients because we're not typically healthcare practice, we don't take insurance, but, they would come in with bulging disc or something else, degenerative disc. But what they're used to clinicians doing is taking a spine model and like twisting it around, And so when they would come in, I would let them know that what that model doesn't show is all the layers of thick, fibrous tissue around it, holding that into place. And so it does seem like the tools that we use in our office can actually create more fear, besides just the language. And what are some other ways that you might address that besides, do you think that therapy, so say a clinician has somebody come in and they're having difficulty establishing that therapeutic alliance, are there other ways besides trying to get them to do something that they may be fearful about doing and they don't want to try? Are there other things that can be done to help contribute to that therapeutic alliance?
Yeah, well, absolutely. And if you don't want to introduce V.O.M.I.T on day one and go against all their beliefs, then the best thing we can do is not add to them becoming V.O.M.I.T or not adding to their catastrophization. I will quote, it was Gordon Waddell. He said the number 1 cause of chronicity or chronic low back pain, for example, is the over-medicalization of it. Now, I certainly went through a phase of over-medicalizing low back pain because that was my education in the last 27 years, most of it. It's the facet joint that's blocked, that's not gliding. It's your multifidus that's weak. Your left side's not firing. It's your disc that's bulging out posterolaterally causing the pain. And I gave that jelly donut analogy to umpteen number of patients. The jelly donut analogy is when you bend forward, the jelly comes back. You go backward, the jelly goes forward. That was my mantra. I said it again and again. In hindsight, I go, oh, I wish I hadn't said those to my patients. But I was innocent. I thought it was a benign thing telling him about the jelly donut. But the problem with that is I made them a victim of a fragile spine, meaning that if it moves like a jelly donut, the disc, when they bend forward to pick up, I don't know, a pen or the bed sheet, change it, they say, "Oh, my jelly donut just came out." And then it's just a horrible image that I gave my patients. And I gave them an image of instability. You have clinical instability, meaning your vertebrae moves like this. So you don't have to give the vomit poster information. You can just avoid giving these bad information to people. And it's been a decade now that I'm not doing this anymore. But you can say most of my career I did because everybody else did, and that was my education. Now with the advancements of research, an understanding of the brain, an understanding of the nervous system, we got to do our best as clinicians not to over-medicalize, catastrophize, and give people false information.
And on that note, when you're just about your personal story, how did you change how you thought about that and how you worked in your practice? Because I think that's a problem with a lot of clinicians, is that they see this new information, but they don't really understand how are they going to get over there to start using it. Because of our education, that's what we learn. So that's what we tend to want to stick with. What was it that helped you on your journey?
It's a gradual transition. I don't think I woke up one morning and say, aha. And for example, I devoted 10 years of my career to manual therapy, learning manipulations. I did my master's, doctorate in manipulations. Now, mind you, I rarely do it now. Once every few months, I may do manipulation. I used to do the McKenzie stuff. It was all about the structure, fixing the disc, getting the nucleus back. When I did my soft tissue release stuff, it was always fixing the trigger point and releasing the soft tissue and the thoracolumbar fascia to cure pain. It was structural based. And how could I not believe that? Because my mentors, the guru people I respected, believed that. And I don't blame for believing that and then gradually when I did courses with other people, for example, Peter O'Sullivan at San Diego Pain Summit. Now, I listened to him talk in 1999 when I was in Australia, right? So that's going back a long ways. And he's done a 180. Mm-hmm. in his thing, because he was all about the spinal instability and core strengthening and stuff like that. So when I see someone like Peter O'Sullivan do a 180, I said, wait a minute, he had his PhD in this stuff. And he says, I was wrong. Maybe even though I've devoted, 15 years, like full-time studying, spent thousands of dollars on these education stuff, maybe I am wrong. So I'm just giving one example as Peter O'Sullivan. Then Brian Mulligan, who says, you know what, we don't need to look at the structure and PIVMs and PAMs. You just go with the direction that makes them feel better. And of course, McKenzie said that all the time. Directional preference. Forget about what structure it is. You go with the directional preference. What does the patient say feels better? And even McKenzie, they moved away from the disc movement model with the advancement of research and technology. So it's gradual. Mm-hmm. With experience. And now I get such greater results dealing with my patient's mind and assurance rather than any fixing a structure. My results are incomparable to the times when I used to try to fix my patient. It just isn't. And my therapeutic alliance is so much better. I have a caseload. I got a 2-month waiting list for my patients. And most of them I don't even touch or try to fix them. How does that work?
So when you were creating your poster, I'm guessing it probably didn't look the exact same 10 years ago that it does right now. Did you have to change did you notice, like, say you set up the original, I don't know if it has changed, but say you set up the original copy, was it, if you noticed patients had a hard time understanding certain things, did you have to make changes based on that? And if so, what was that journey like?
Yes, it is. I try to take out big words out of it. Sometimes you may think there's two groups of people who you want to impress using big words, other people, I've realized, you know what? I don't want to impress my patients with big words. I want to dumb it down. Not because they're dumb, because for myself, there's no point. And it's the same way I had a belief that my patients want to know about what is exactly the structure wrong with their neck, their back or shoulder. because people say they want to know. I don't tell my patients, and they're quite happy not knowing. It was my belief that people want to know exactly, or they want to know big medical terms. They don't. So I've pretty much taken away a lot of medical jargon words out of this. And it's worked well. So you're correct. And the only thing that's happened, I've simplified it. And of course, I update the references in there. But I don't want to make it too busy, the poster. So I already had, 15 references in there. But, one for each body part or a couple for each. The way it's evolved is I've really come down to the point of the simpler, the better. The less medicalization, the better. Gordon Waddell said that, as it did Alf Nackhamson. Both are, orthopedic surgeons, world-renowned people.
Are there any aspects of the poster that you get the most comments on from your patients?
Yes, because the one that's most shocking to people that they become, and unfortunately some physicians do BARF most often. BARF stands for Brainless Application of Radiological Findings. So patient has, I got neck pain, doc. I woke up in the morning, I have neck pain. I've had my neck pain for a year, whatever it is, 1 month. They say, let's take an x-ray. They get an x-ray. What do they find? Degenerative disc disease, arthritis.
We all have that, I think.
C5-6. No, not all of us. And then I told them, do you know what percentage of people with no neck pain have degenerative changes in their neck? 98%. 2% of people are freaks of nature that don't have degenerative changes. So 98% of people have this? Yes. So how can we possibly blame the neck degeneration as your neck pain? Because it didn't happen a year ago, this degeneration. It didn't happen a week ago or a month ago. You've had this for years and decades of your life. And the other thing that's surprising to them, whether it's in the lumbar or neck, it starts from age 20 onwards. So for example, 25% of people age 20 to 22 when they did x-rays had degenerative changes in the lumbar spine. So 25, 1 in 4, this is age 20, and are asymptomatic, by the way. So the two shocking thing is how prevalent it is, 98% in the neck, and how, what a young age it starts at. 20s, it starts. And it's normal. It's not associated with pain. I want to find one study that says it is. It's just not. My grandmother has severe degenerative disc disease. I know that for a fact. Every level in her spine. She's 92. She used to be like this tall. Now she's this tall. She's lost like 20 centimeters. Like, where did she go? Right? She's obviously has severe degenerative disc disease. She has no neck pain. I assess her. She can touch her toes, bend forward and touch her toes. She has severe spinal stenosis at every level in her vertebrae. No pain whatsoever. How do you explain my 92-year-old grandmother? If you were go by the radiological model that pain causes, degenerative changes causes pain. Her hips and knees has zero disc, zero cartilage in them. I can only assume that at age 92. She can do a full deep squat and get back up.
Well, now it's time for her to start selling a supplement, and she can
Yes.
say she's been taking that supplement her whole life.
She's been taking nothing.
And, when it comes, and these stats are really, it's powerful information because it's true. I mean, degenerative disc disease is just part of life. We just happens, And so what about the patients who they're on board and they're like, they trust you, but they're confused. So why do I still have pain? What are some things that you might explain to them or talk to them about? Because I'm sure a lot of clinicians who are listening to this, they work on these therapeutic alliances to talk to their patients, and their patients are like, you know what, that makes a lot of sense, but why am I still in pain? What are some ways that you might address that question?
Yeah, I've been trying to get around that myself, because not only, patients want to know what structure it is, I often want to know why they're in pain. And I've reached a point where I'm very okay with not knowing. All right, I just don't know. And the truth is, doctors don't know. So the word that I use now, for example, if it's knee pain, like I had a runner today with knee pain, my diagnosis 90% of the times right now, neck, back, is you have a sensitive knee. That's my diagnosis. You have a sensitive knee. It's sensitized. And how do we desensitize your knee? By exposing it to the thing that you fear doing, or the thing that actually aggravated you repeatedly, but every day, but short of making it more sensitive. The only way to desensitize a part of the body is actually exposing it. And I tell them, let me tell you what doesn't work when a part of the body is sensitive, is resting it. It actually becomes more sensitive. You can rest it for a month. You can put your leg in a cast. We can put your back in a back brace for 6 weeks. You know that if we took the brace off after 6 weeks, after the cast off, you'd actually have more pain because lack of movement makes the body even more sensitive. Fear makes the body more sensitive. And exactly what structure is sensitive? Well, the cartilage, the bones, the nerves in the area, the muscles, the tendon, anything can become more sensitive. So I say you have a sensitive ankle. Like a guy with heel pain today, I said, he said, I have plantar fasciitis. I said, actually, we've stopped using that term because the studies show there is no itis in it. And he's done his course of anti-inflammatories, which hasn't worked. He's had orthotics, 2 of them. He's changed his shoes. So it's probably not inflamed, and he's had shockwave therapy, lasers, done everything. It's not plantar fasciitis. Let's get away from that term because the studies don't support it. I say the term now is used plantar heel pain, which I don't like the word either. It just means you have pain in your heel. But that's what's used in the research studies. I say you have a sensitive heel. Does that make sense?
What did he say to that?
He says, yeah, okay, what do I do about it? You know, you've been avoiding running, right? And you've avoided jumping. I got him jumping. That's what I did. So expose the heel to actual jumping. How does that feel right now? Well, it doesn't feel bad now, but it's first thing in the morning when I get up, it's worse. I said, you know why it's worse? Because when you rest it, it becomes more sensitive. Because all night or when you're sitting for a long time. So we got to constantly expose the part of the body that's become sensitized. It's your neck. We got to constantly have you desensitize and moving it, which goes with what McKenzie said, Robin McKenzie, constantly move it or every 2 hours in a direction which doesn't make you feel worse. So sensitive. You have a sensitive shoulder when you lift your arm up. That's it. Sensitive back. It seems to work. It's the least medicalization thing I can do.
I see. So your patients seem to respond really well to that then.
Absolutely, because there's no structure to look at then. Because when they view, it's my cartilage, it's my meniscus, it's my ligament, then they can view something. And heaven forbid they Google it, then I've lost them.
You lost them to Dr. Google.
I want to take the visualization of something structurally wrong in their body out, no matter what part of the body it is. The analogy I can give is, let's say you had a headache, mild headache. You Google causes of headache, brain tumor comes up. Now, if you visualize a brain tumor in your head, is your headache likely to increase or decrease? I say that. Is your headache likely to go away quickly or persist for a while? If you truly believe in your head that you have a brain tumor. And so it's likely to increase. And that's not just pain being in your head, you know, it's all in your head. It's real pain. Your headache will be real because you visualize the structure in there. And that will happen inevitably. It happens not just in the brain, every part of the body. You visualize that tear, boom, you become sensitized. You visualize the degeneration, boom. Another story, I had a lady, this is a few years ago though, which was an extreme. She moved her neck like this. I treated her for 3-4 sessions. After a few weeks, I noticed I wasn't getting anywhere with it. I said, do you know why you're guarding your neck so much? You know, there's a reason. He goes, in the end, it came out suddenly. He goes, I had the x-ray and I know I have bone spurs in my neck. And I'm worried if the bone spur, if I turn my neck too much, it'll sever my spinal cord and I'll become a quadriplegic and I don't want to be a burden on my family. That was going through her head. And it took me a few weeks to get that. But it was, you know, I should have gotten it earlier in hindsight. But what people believe, we have no idea. Bone spur, what does that sound like? Sharp, jagged knives coming out. And if she turns her neck, it's going to sever her spinal cord. And she's heard people who've become paraplegics and quadriplegic. And she doesn't want to be, it wasn't about her though. It was about, she didn't want to be a burden to her family. So hence her muscles tense up that she won't move. I can do all the manual therapy in the world, every drug she can take, but I needed to give her a dose of reality. It didn't come like this either for me to change her mind, but eventually I did. So it worked, but it took a couple of months.
And that just happened through communication and then,
correct.
And you know, the graded motor imagery that you kind of discussed earlier and that sort of thing.
Yeah. And their reassurance and building that trust. The bone spur is irrelevant. You will not, in the history of mankind, no one's ever severed their spinal cord.
I haven't heard of such a case.
People believe what they think they should believe.
Mm-hmm. Which is given to them by their many medical health professionals.
Now, I have to admit, the medical professional never said about severing a spinal cord, but we give those subtle hints, but then leave the patient just like that. You just tell them in passing, yeah, you have degenerative disc disease in your neck, in your thoracic spine, right? You have a disc bulge in your thoracic spine. Yeah, like 70% of people have disc bulges in their thoracic spine. But if you just say that, then they'll say, oh, shit, I got a disc bulge in my thoracic spine. They never finish off saying, you know what? But that's normal. You have arthritis in your knee. They don't say, well, 85% of people have arthritis in their knees.
So they give that first half of the story, but not the epilogue, right? And then the patient goes home and goes right to Google.
Yes.
To find out the rest of the story.
Yeah.
And that's what. Oh no, go ahead.
I was saying, and the solution is so simple. I've been trying to advocate it, but I'm just can't get through the front door of physicians and radiologists. I'm just not important enough in the hierarchy of the medical world to be able to go through. But the study was published, and it was an amazing study in the US. It was where they took, and half the radiologists were made to do this at the bottom of the radiology report. Write down 2 sentences what the normal findings are for that age of a person. You know how when you get blood work, it shows your iron level, the range, what is normal, this is too low, this is high. Your triglyceride, this is too low, this is high. Your sugar level, this is good. We have normative data. So when you can compare yourself in whatever potassium and your sodium, whatever there's there, that where you are, what the normative findings are. Patients go by that and doctors go by that. This is where you are, but it's well within the normative range. Why don't they do that for radiological? If they only put that one sentence in, this study showed significantly reduced surgical rates and significantly reduced opioid usage. 2 sentences typed in automatically. I don't know why it's not standard now. I still don't know. And that study goes back to about 8 years ago now.
Oh, wow.
It should be standard.
Mm-hmm.
You just put in 2 sentences. So one, the physician knows. Second, the doctor knows. The patient knows. So if the patient read, you have degenerative changes in your C5-6 and you're 53 years old, the study showed 98% of 53-year-olds have degenerative changes in their necks, which is within normal limits. That's it. Just say that. Boom. You just eradicated so much surgery and opioid usage.
Yeah, it's tough because I know here in the U.S. medical education system, I saw a conference with President Bill Clinton on the opioid crisis a few years ago, and there were a few physicians there and some other people. And one of the physicians had gone to Harvard, and she said that in her medical program, I think they only spent like 15 hours on pain, or like 4 hours or something.
Yeah.
I mean, it was a really low, I can't remember the number, but I remember just thinking, wow, that's why they don't understand about language. And so hopefully there will be a change just in the basic education itself, for those professionals. But, as we wrap up our discussion here, and this was really cool information about your poster, which we're going to link to. People can order it on your site, correct?
They can order it. It's $20. It's on Amazon also, but the Amazon in Canada.ca. But it's also for free to download in those 8 languages that I said. And if they just go to my website, APTEI.ca, under pain education, all the posters are high definition images to download themselves, and they can give it to a printer to print it for themselves. I didn't make the poster to make money from it.
You just want to get it out there.
Yeah.
That's cool. Yeah. And we'll include that link here on your bio page so that the clinicians watching can download it and start working with it. And so what's one thing that you would recommend for the clinicians who are watching this and say they're going to go back to work tomorrow or on Monday? What is something they can take away from this discussion and start using immediately in their practice?
Avoid using these terms, jargon. Avoid using the jargon disc. The word disc I don't use to my patients anymore. I don't use the word degeneration. I don't use the word osteoarthritis. In fact, I detest that word just because I think it's caused more people problems than it's ever helped that word. And it's false osteoarthritis. Simply my grandmother being the case. How else would you explain my 92-year-old grandmother? That she has zero pain, she walks on her own, she goes up and down the stairs independently on her own. So I know we're brainwashed to believe that stuff, but it's just not true. People have sensitized joints. Now, the cause of that sensitivity can be hormonal imbalances, can be cortisol levels, can be inflammation in the body that's released because of, various things. But it's not because an actual tissue problem that's causing the pain. So walk away by using the word, you have a sensitive shoulder. What structure it is. But there's multiple structures that could be it, but it doesn't matter. Our goal in physiotherapy is to desensitize you. Our goal with massage, as I even rub it, is to desensitize the area, not to fix it. My goal for doing acupuncture or dry needling is to desensitize the area and your nervous system.
And I'm just going to add real quick before we end this session that I would imagine it's going to take a little practice. So if you want to try that at work with your patients, don't be so hard on yourself if you fall back into that, or I think it's something that just has to be changed slowly with awareness, it seems like.
Absolutely. It's gradual. It's gradual. And as you see results, people getting better, you say, wait a minute, that patient got better just by me changing my language, and I didn't even have to treat them.
Cool. Well, thank you so much, Bahram, for joining us. And I appreciate your time today.
My pleasure.
And so they're going to cut this part, but let me turn off just stop.